mention that I need to look at some of the things related to what has been done so far. So I felt that I should get out quickly where I am. So you've heard about Partners in Hope. As a programs director for Partners in Hope, I'm responsible for the programs. The Partners in Hope has the medical center, has the programs, and it has the, some of the operations and the implementation science. So I'm responsible for the PEPFAR supported program through USAID. And I came in to find the 2.5-year program. Now we've just started a 5-year program, which is the care and treatment for HIV in 9 districts in Malawi, listed on this map. And that's about 123 health facilities currently are taking care of about 200,000 patients who are alive on treatment. And on this grant, as I already said, we actually collaborate with UCLA, and we have also a local partner in Malawi. So I felt that let's just do a couple of definitions because of what I might probably mention when I'm presenting later on during the presentation. And in this case, you can see that I thought about epidemic, which is a sudden increase in cases of disease. And then we talk about pandemic, which is a spread over several countries. As for now, we're talking about COVID-19. Endemic, these are the constant presence of infectious diseases. For example, in Malawi, we have malaria. So malaria is an endemic disease actually in Malawi in this case. Hyper-epidemic, which means persistent high levels of disease occurrence. But the key ones which I thought you should remember are the incidence, which are the new infections per 100 population over 1 year, or the prevalence, which is the number of infected people per 100 population at any point in time, and then the AIDS mortality, number of deaths from HIV per 100 person per year, and finally, deaths among people living with HIV, which are the number of deaths among people living with HIV from any cause per year, all-cause mortality. So I thought we just get away with those terms because we might meet them when we are talking here. Good. So let's talk about HIV/AIDS and the global update. You might be familiar with this, and what I would do is I'm thinking that I just emphasize the point of saying that HIV current total, which is a global report by UNAIDS of 2021, which is basically talking about 2020, about close to 38,000 people living with HIV around the world. And this is where you are, so you know what the burden is where you are. But I wanted to bring your attention that 67% of this burden is in sub-Saharan Africa. So it's here and below, 67% is around there. And then you've seen what the other countries are. In this case, we're talking about the estimated number of adults and children who are newly infected. This is our incidence. And you see also, this is where you are. But then for about 58% are within the sub-Saharan Africa here. And this is where also I am in this case. Now, coming up to the estimated adult and child deaths for adults, and these total about 680, and this is where you are. And however, this is what you find. This about 68%, the burden of those deaths are in sub-Saharan Africa, which is this area. So let's just look like over time, what has been the trend within the 3 domains. And this one actually, in this case, we're talking about the trends over a period of time. You can see that the number of people living with HIV has been exponentially going up. And what I wanted to emphasize, a point over there, is that because of treatment, it means that we have a lot of people living with HIV, and with a reduction of deaths, you would have a lot of people having that. So this is a trend from 1990 up to about 2020. If you look at the number of new infections, the good news is you've seen a reduction. When antiretroviral drugs were introduced, basically in the mid-90s, you've seen a significant reduction on number of new infections coming down over here, which is good news for the HIV in this case. Number of deaths, the peak was around 2004, 2005 for number of deaths, but we've seen that over a period after 2005, with scale up of antiretroviral programs, you've seen actually a reduction significantly of number of people who are dying due to AIDS, which is good news in this purpose. So I thought we just take this away just to have a global picture of the HIV in this case. Therefore, let's come to Malawi, where I am, looking at the HIV situation in Malawi. This is a summary of the Malawi HIV program, and in this case, you've seen basically in this case, the Malawi is bordered by Tanzania in the north and Zambia in the west, and then Mozambique in the east and part of the southern part. So 18 million population with an estimated number of people living with HIV about 1 million. And about 9% adults, that's 15 to 49 years, with new infections around 20,000, with a yield of 3%. The total fertility rate is about 4 births per woman in Malawi. And on the HIV program, as of March, in this case, sorry, as of March 2021, this should be March, 871,000 patients alive on treatment as of March 2021, which is 88% coverage, which means 88% of the people who are living with HIV requiring antiretroviral drugs were starting antiretroviral drugs. And this is about 89% amongst the adults and about 78% amongst children. Where currently we have the dolutegravir regimen along with the tenofovir, and in that case with lamivudine, which is the first line, 97%. This has been a transition from 2019. Number of people who come back to pick up their medication at 12 months is around the proportion about 73% for adults and the 76% for children. So this is just a summary of about the situation. So I felt that in Malawi, let me just show you the demographics for HIV. If you look at the HIV prevalence, the southern part of Malawi is a high density population area, seconded by the second region, the central, and then the third, which is the northern region, which is very hilly over there. And this side, we have tea plantations and coffee plantations, and also some other fishing along the lake, which is here, Lake Malawi. So the HIV prevalence is higher in the southern region compared to the central and the northern region. And the Blantyre is the largest city and the commercial city in Malawi, which has the highest HIV prevalence. And in this case, Lilongwe, where I am, is the capital city, and it has actually about 11% over that. So this is just to show in terms of what we are seeing as the distribution of HIV, its epidemiology in Malawi. If you look at it by sex, we want to know where is the main burden amongst men and women and which ages. You realize that the burden is more amongst women. As you can see that actually the women, which is the light blue, you can see that is picking up as far as 24% at the ages of 40 to 44. While actually the men are actually picking up around 20%. What is good news is that over 50% of the Malawi population is below 15 years. And you can see that below 15 years, the prevalence is still very low, which is a good thing to make sure that as medical students, as you think about your career, as you think about venturing into global health, you would be able to look at making interventions significantly amongst this young population to make sure that as when they grow up, we should distort this by lowering it so that we should not have that as high as what we are seeing here by doing all the preventive measures around actually this area over here. And then looking at the trends of HIV prevalence, as you can see, there was an issue of picking up around 2000, but then there was actually a decline and stabilization. There was a component of competing deaths with new infections, but as you can see, this is an estimate, and men and women, still women higher compared to the men counterparts. And there are some attributing factors to that, and this is because the girls actually would be exposed at an earlier stage to HIV, because one thing which happens within the social clusters and structures, all the older men would be rushing to the young ones thinking that their older ones have HIV. So they are shifting the HIV burden to the young ones. But also poverty contributes to say that the transactional sex would be also one of the contributors which would contribute to why we're having the women having a higher prevalence compared to their male counterparts. So this is just emphasizing the point of the trend of the like epidemic in this case in Malawi, with the women being a bigger proportion, men actually over that, and then children, as I mentioned before. So I'll not stay more on this slide. The few three slides are very busy, but I'll not stay longer. This is just to emphasize the point of that where most of the people living with HIV. As you can see, most of these districts are in the southern region of Malawi, and we've talked about this before. Similarly, we're talking about new infections. Most of these districts are southern part, except Lilongwe in the center, and most of these are these ones which are really quite dark blue in this case. And then the ART coverage. The good news is that Malawi, and actually when I'm presenting this in Malawi, I usually ask the Malawi audience, including students, to clap hands for Malawi for the ART coverage that has happened so far. So I'm not sure whether the team here, by nodding, that they will join me, that they're clapping hands for Malawi for this component. Thank you, Risa, for that. So what the emphasis is that, as you can see, the ART coverage is the majority of all the districts are above 8 and above, except in this case, one district, which is, but all these are basically 8 and above, which is a good process. So if you are looking at definitions later on, we talk about epidemic control, and I will talk more about this. But this is about coverage of antiretroviral drugs in Malawi. And this one is just looking at the number of people who are living with HIV, but are not aware of their status. Currently, this number has shrunk to about 83%, while in the last 2 years, it was about 83,000, I should say, sorry. While in the last 2 years, this was about 300,000. So this is a narrow window that Malawi is heading to make sure that these are identified and that they should be put on treatment. And then you have the pockets of where most of these are, especially in the southern region of Malawi. Okay, so I felt that before I move on now to how the services are provided, and in this case, we have, it is guided. I talked about the national response of HIV. So Malawi National Strategic Plan this has been for HIV, has been operating. Now we have a new one, which started last year, which actually is coming to an end in 2025. And this is a blueprint of the HIV national response in Malawi. The key components of this blueprint is that the overall objectives are to reduce new HIV infections from 34,000 in 2020 to about below 12,000 in 2025. To reduce HIV and AIDS-related morbidity and mortality, and reach the 95 treatment targets. These ones, I'm sure you've read about these. UNA's, the Joint HIV/AIDS program, looks at 2020, it was 90, look at 90% of the people who are living with HIV to know their status. 90% of the people who know their status are started on antiretroviral drugs long-term, and then 90% are virally suppressed, which means they're living well without active virus. And in this case, this has been pushed to 95 by 2030. But in this case, 2025, in this case, we are looking at towards the ending AIDS by 2030. So the Malawi National Strategic HIV Framework is looking at it to reach at least in 2025. Improving the quality of HIV services and making sure that the service, there's a self-sustainability, so resilience of health and social welfare statuses. So let's look at how Malawi has done in a couple of services that is provided. We look at, in this case, this is HIV testing. You see that these are the tests that are done, and we are looking at from 2008 up to 2021. And as you can see, there have been issues around the ramping up the services. The green are negatives, the red is positives, and you can see the number of positives has been reducing, the finding of them, because most of them are being tested, because these are new positives that we are finding. So currently we have a yield of about 3% from the yield of what we're seeing before, that I will show in a little bit later on. So this is HIV testing, which is the first 95, or the case identification. And in this case, the blue is apart from the testing by the providers, we are also providing the oral quick, which is the oral self-testing, which increases the number of people testing. And as you can see, previously in 2008, we were having a prevalence of about 15.8%, but this has actually declined over a period of time to about around 2.4, because a lot of people have tested in Malawi. So the new positives actually are very few. As you remember, I said 83,000 people are the ones who are not aware of their HIV status. So let me just explain on this one, looking at the number of the 95 targets. So the National Strategic Plan here is talking about for up to June 2025. These are how the 95 would be, but then scale up target for 2021. We were supposed to have about to reach 93% for testing, 94% for starting treatment, and 95% for viral load, if we were able to put these people according to the plan. However, 2021 Q1, we've already surpassed the first 95, which is 96% of people actually know their HIV status, compared to the way we're supposed to reach in 2025, and 92% are currently alive on treatment. And we are short by 3, but remember, we are in the second year of the strategic, but we have 3 more years to come to reach 95. And finally, viral suppression is at 94, short by 1, but this is 2021. The 95s are set for 2025. which is another reason for clapping hands for Malawi for the progress that has been done so far in these ones. I thought that not all is rosy as we're implementing the program. There's a component which is about the ART dropout. So the people who are on treatment, and then to see how many of those actually are dropping out. And you see that previously there was a 2.2% of people not coming back to pick up their medication in a quarter, and that has been reduced to below 1% actually as we're finishing 2020. This is part of the initiatives which have been put by implementing partners, including, for example, Partners in Hope has a card of what we call patient supporters, who do patient reminders to patients to say, you are due for treatment to pick up your medication tomorrow or next week, please come. So these are some of the issues that we would see in that component. And then this is actually the what we call the transition, moving from what was a 5-year regimen now to dolutegravir regimen. And now, as you can see, that we moved from 2019 from 38% to, as we move in 2021, to about 97%, which is universal. So anyway, with this, let me just show you that there was a difference before in terms of the viral suppression between males and females. But over a period of time, there's no difference, as you can see, male and female. There's no difference between male and female in viral suppression. And the explanation I give is that whether you are male or female, the blue is male, the red is female. Whether you are male or female, if you have a viral load result, it means you came to the facility. If you came to the facility, you are more likely to be taking the medication, then you are more likely to be suppressed in this case. And I just wanted to show you that. And because of Malawi being busy with over 8,000 patients alive on treatment, for them to be coming every month to pick up medication or every 2 months, we've split them into that others can come every 2 months, or some of them can come every 6 months. So the 45%, for example, in January to March 2021, were patients who were coming to pick up medication for 6 months, and then 48% for 3 to 5 months, and then 7% for 0 to 2 months. These are the ones in 2 months. So I just thought I would share with you some of what you call differentiated service delivery to decongest the facilities, at the same time to make sure that people are coming, you are reducing their out-of-pocket expenditure. Now, epidemic control. With that good progress, we call epidemic control, whereby the new infections and the new deaths are actually almost crossing over there. So I wanted to mention that the new infections is the green, while the total deaths is the orange, and then they have crossed around 2004. And as you can see here significantly where now they are meeting, it means that new infections are almost equivalent to the deaths. Therefore, growth of people living with HIV has stopped. And this is what is actually labeled as epidemic control. And I'll come back to that as I'm finalizing. So how should we define epidemic control? The epidemic control is sometimes defined as standard for infectious diseases incidence, which is less than 1 infection per 10,000 population per year. So in this case, it's about 0.01 as incidence. So remember, we talked about incidence. What HIV incidence among adults more than 15 years in Malawi, it's about 0.17%, which is 17 times above generic threshold. Therefore, is this epidemic control? We need to talk about that. How many people die from AIDS each day in Malawi? There are about 10,800 AIDS deaths per 365 days, which is equals 30 AIDS deaths per day. But look at COVID. COVID, for example, in this case, this was 4th August, 29 new deaths. on that day. I know these deaths are more as for Malawi standard, but if you look at them for the US, they look like low. So there's a lot of noise about COVID now, but as you can see, AIDS deaths per year in Malawi is about 30 deaths per day when you look at it. So I wanted to make that comparison too. So the last part of this presentation is to look at now the integration of, in this case, non-communicable diseases into routine care. Why are we integrating it? Because people are living longer. Therefore, the people are living longer, they started to actually have diseases which are actually equivalent to the people are living longer. So in this case, we have the infectious diseases, which are leading cause of death, but they are important risk factors for cardiovascular disease, and then HIV infection may cause inflammatory activation. So that's why we want to talk about non-communicable diseases. And the trend in Malawi has been that integration of cervical cancer screening was done basically within HIV care in 2007, and then the implementation of hypertension in 2015, and then a national policy in 2016. So currently, facilities are integrating screening of hypertension, screening of diabetes, screening of mental health, and in this case, screening of cervical cancer disease. And this is the national hypertension burden for HIV cohort. And this is just to say that close to about people who are above 30 years or so, these are the ones who are screened for actually hypertension. And so you can see the proportion of the number of people who are screened, about ranging from 18% to 35% to 43%. But this is like a low coverage, but in facilities which are supported by implementing partners, this is really high. So I thought I'd just give an example of integrating non-communicable disease, just an example for my previous job, which is at the Lighthouse. And in 2015, whereby all blood patients 20 years and above, weight and height, blood pressure, and a reminder on the annual cervical cancer screening. And what was found was that within a cohort of 3,000, 46% were 40 to 49, and the prevalence of hypertension was 16%, twice as in females, in males compared with the females. And the pharmacologic treatment for 6 months, there was a 38% for mild cases, 30% for moderate cases, and 21% for severe cases. So ART adherence for the hypertensive patients receiving hypertension medication was comparable with patients not on hypertension. So this was 80 to 79% in that case. I felt I should mention about this one is a busy slide, but it's just to show that the prevalence of hypertension was lower in the cohort of the patients in these facilities compared to the national survey. It is because of the definition of hypertension, which is to say that we should have at least 2 measurements on at least 2 occasions. While this one, the blue, this one, the blue, they were actually doing anyone with a high blood pressure was considered as hypertension. So in this case, these are just metabolic cardiovascular risk factors for obesity. And just to mention that there was a component of hypertension grade, diabetes was in 4%, but the lipid disorder was about 25%. So finally, HIV and the NCD integration, final thoughts. There's tension between differentiated care models, especially multi-month prescription with integration of non-communicable diseases. Availability of blood pressure measuring devices can be an issue because of costs and the usefulness of screening for other diseases, for example, diabetes, hyperlipidemia, is clearly only useful with access to adequate treatment. But the opportunities are that leveraging the successful HIV clinic structures, this is important, and it can normalize HIV as a chronic disease with a possible reduction. So I have 2 slides to talk about, after talking about that, what has been my role in the partnership with the UCLA, USC universities. So I have had I am a faculty of the University of North Carolina because of the linkage of the UNC project in Malawi. And I have led several like consortia and studies as a PI or co-PI. And the one which is highlighted here is about an NIH supported grant for HIV-associated malignancies. And working with the team from here in Southern Africa, but also in the US, what I find is that we sit together at a place and we have equal contribution to what we are making. That makes my life exciting because I know that I can be able to teach within the universities, share experiences from here. At the same time, we work together and develop programs that we'll be able to see in Malawi. Similarly, our partnership with the University of Washington in Seattle, with the ITEC, the International Training Component for Education Center, and leading the Lighthouse that time, that gave me an opportunity to have several studies which are also in co-PI, and I'm able to provide teaching in leadership courses and also some of the clinical epidemiological courses, and that gives me a leverage to share what is available in Malawi. And currently, I'm 1 year to PIH, and this is now found in this incredible collaboration with UCLA, and that's what gives an opportunity to talk to you guys this afternoon here and this morning that side. And the main issue is that we work with UCLA to look at the implementation sides, designing interventions that will be able to assist the national response in Malawi to make sure that Malawi continues to sustain the epidemic control. So as medical students, as we go into now the think about global health and some other components, one of the issues I would encourage you is that you will be able to meet different people from different places. And what I usually tell people is that when you're on the table, you actually understand what people are thinking, listen with very clear ears, and see what their thoughts are, and then start to bring down your thoughts to share with the colleagues. And Lisa is aware about this. I usually use what I call the mango analogy, whereby I say that when you come, I know you guys, you eat mangoes most of the time from the cans or from the cartons. But here, especially now, we go to a tree and pluck the ripe ones, which are really good because they're fresh over there. So you see, when you shake the mango tree, the ripe ones and the non-ripe ones would fall down. The non-ripe ones will be sour even if you put them for 2 or 3 days. So what I use that analogy is that you should keep one idea at a time rather than just shaking ideas when you're sharing with colleagues, either when you're in the US or whether you have gone actually on a global program when you're coming over that. With that, I would like to thank you for surviving this marathon of a story about Malawi. And I'm proud to be associated with Partners in Hope and proud to be associated with UCLA as in this partnership. And today I finished there and will pick up some observations and some questions at this point in time. Over to you. Thank you very much.
Thank you so much, Dr. Phiri. That was a wonderful presentation and covered so many topics in such a short period of time. I know that there might be some questions from the group, but I'll just kick us off while some people are getting ready. I wanted to ask specifically with regard to the delivery of HIV services, as well as the delivery of HIV and the non-communicable disease services, what is the primary healthcare workforce that's involved in the delivery of these services? And what is the kind of setting that these screenings are happening in Malawi?
Good. Okay, thank you. So as the team is prepared, yes, I could take that one. So one of the success factors for the successful implementation of the HIV program in Malawi, because the demography of the medical team, you have amongst the clinicians, you have the medical assistants and the clinical officers. The clinical officers are an equivalent of the certified physician assistants. And these are very experienced in the delivery of healthcare, and they are a backbone also of the healthcare delivery in Malawi. Then you have the doctors, in this case with MBBS, MD, very few actually specialized specialists. Now, in terms of, then we have the nurses who are also the diploma nurses, and then bachelor's nurses who are called the registered nurses, who would be equivalent to the nurse practitioners or case managers in this case. And the delivery of the providers for HIV in Malawi. HIV testing is done by a lay cadre, non-medical, which are called the HIV diagnostic assistants. These have a crash course of HIV testing skills, and then they will start to work as HIV diagnostic assistants, and these are public health cadre. Then the initiation and the follow-up is done by either a nurse or a clinician. Clinicians, the majority of clinical officers, medical assistants, and also medical doctors in this case. Then the more experienced clinical officers and medical doctors and specialists, equivalent of people like Lisa, like Prof. Youth Vanistu, that Partners in Hope, would be also looking at the second line and the third line management of that. In terms of for non-communicable diseases, similarly, the clinicians, so the nurses, mainly the vital signs like the blood pressure, weight, and height will be done by the lay cadre, and then this would be available with the nurses to repeat or the clinicians to repeat. But the initiation of the hypertensive drugs is done by clinicians only, but the refill can be done by the nurses if they are stable on treatment. So this is actually how the structure is. Because of that, that's why Malawi has over 700 sites providing antiretroviral drugs. And then you have the standard drugs like first and second line of hypertension would be available in these sites too. So that's what I would say for this component. Over for now.
Thank you. That was very, very helpful. I want to be mindful of time and defer to the group. Does anybody have any questions they would like to ask first before I ask anything else?
I'm happy to ask a question. Thank you so much, Dr. Phiri. This was really, really interesting. My question is about PrEP and what the status of PrEP access and PrEP delivery is in Malawi. Could you speak a little bit to that? Thank you.
Thanks very much for that question. So yeah, actually on the program that we're implementing at Partners in Hope, the third objective of the core program is the high impact actually prevention and mainly focusing on pre-exposure prophylaxis. So Malawi, in this was one of the areas where Malawi was behind on the implementation of the PrEP program. But in 2019, that's when most of the guidelines and policy came forward. So 2020 actually, now the designated sites, including moving into 2021, all the district hospitals have been moved on to be started on pre-exposure prophylaxis. So now this is given to high-risk groups. So for example, If someone is in discordant relationship, then they will be given actually PrEP. Those who are actually the adolescent girls and young women, they will be given PrEP. Those actually, for example, within the key populations in this case, men who have sex with men and also female sex workers, these are actually also would be eligible for PrEP. And then there have been issues whereby it is being discussed on whether this should include also the pregnant women in this case at one point, but otherwise pregnant women who are HIV positive are already put on antiretroviral drugs regardless of their clinical stage or those issues. But otherwise PrEP is provided over that. It is now in its rollout in 2021. Supplies have been rolled out in facilities, and so 2021 is considered as a rollout component within. So the number of people on PrEP in this case has still been low, below 3,000, but otherwise it is an area where now we are scaling up. I would stop there for a moment. Over to you.
Thank you, Nafisa. Are there, and Dr. Phiri as well, are there other questions from the group?
Probably all that did not make sense anyway. I know it was a lot of talk and a lot to take in a time. With permission from Risa, I will be able, so I know it is being recorded, but I can share the slide deck too for you to look at some of these issues.
Can I ask Sam to talk on one final point, maybe? We have time. Okay. So, sure. I mean, so as you clearly laid out, the success of the treatment program is tremendous, and coverage in Malawi, is high, and people are doing well. So this issue of non-communicable diseases is so big, and, hypertension is so common. What do you see as like, what needs, I mean, you showed the Lighthouse data, how integrating, had some successes, but on a national scale, what should be done to really make it possible to treat non-communicable diseases, for people living with HIV, obviously for everyone in the country, but, how does that happen? Particularly if you could comment on the supply chain for medications, and it's currently very weak, and how does that get fixed?
Thanks, Lisa, for that. Actually, I should have mentioned that when I was talking about the Lighthouse data. One of the contributing factors for the success of that program within the Lighthouse was that we were given a leverage by CDC to actually complement the drugs. So in most of the facilities, hydrochlorothiazide would be available, but if you're looking at the second and third tier, those may not be available on the national program. So I think to me, that's when I talked about to say you can have a demand creation to say, go and have your, let me tell you this, let me disclose this. I know that in the US, you can make a decision, I'm sure you correct me, to say, I just want to have a checkup. I just want to have a checkup. I don't have when, after 3 months, I just want to have a checkup. In Malawi, for you just to make, if you come to a facility, you look around, you're like, really? Do I want to say that I just want to have a checkup at this facility? You can just turn back and say, I will leave the team to work with the burden of disease which is available there. So you can create demand to have people to come to the facilities. And then supply chain can be an issue. The HIV commodities are solid because they are 100% under global fund. And because of that, antiretroviral drugs have never run out in Malawi since the national program started on a free in 2004. But drugs for opportunistic infections, because they're not fully actually 100% on the Global Fund, these ones actually do run out at a point. So the only way the integration of hypertension would work well, leveraging on the HIV platform, is to make sure that there is support and contribution to the actually hypertensive, antihypertensives. Actually, they are not as expensive as the other drugs. I remember at the Lighthouse, it actually costed $4 to actually manage a case. So they are not expensive, but it is a priority. So all these are part of the essential drug supplies. But in terms of prioritization, people would prioritize on malaria, would prioritize on, for example, pneumonia and some other components, which they think are diseases that kill. But knowing that if we have people who have hypertension, now in Malawi, I've seen people who just drop. They were in church or they were at a meeting because probably their blood pressure was up and they have a CVA. So yes, what we can say is emphasizing on the national program that availability of the drugs, availability of even the BP machines, even when the BP machines are available, availability of the batteries for the electronic BP machines is critical for us. So I think those who are working in the other programs like HIV care, leveraging the resources within that would also support this program to be successful. That's what I would say, Lisa.
Thank you.
And just to mention also that as part of the Partners in Hope, we are also actually doing several like studies, including a study which we have to look at also, which is including the non-communicable diseases, in this case, hypertension, and just to see, to make sure that look at